Like in Philadelphia, we specialize in the wild, wild west. Like there's no rules, do the crazy stuff, and we want to hear what everybody would do about these cases because in after L45 degen spondy, there's probably nothing with more divergence of opinion than cervical myeloradic. Um, and so we have a bunch of cases curated, which hopefully push the boundaries a little bit there. I'm going to share my screen to get into this, but we're at Rothman, we're very, very happy to be part of the Seattle Science Foundation programming. And we keep coming back because at the end of the day, it's sort of like more interesting than most other formats for discussing stuff, which are a little more buttoned up. Is this working?
Yes.
I think it is. All right. So, myeloradiculopathy, dealer's choice. Like maybe in like that's maybe not enough question marks and exclamation points to like drive the point home.
Put it on your
Um,
presentation mode, though, Chris.
oh, is it not going? Okay, hold
Yeah.
on.
Click in
There we
your
go. I'm
lower
sorry.
right.
Yeah, I'm with you. I'm with you. Okay, sorry. I'm with you. Um, there at the bottom, I'm just gonna plug for my Instagram handle if you want to see some wild stuff that comes out of the spine in Philadelphia. All right. Financial disclosures, none of which have anything in particular to do with this talk, other than, in general, spine surgeons get paid to do surgery. So we're going to talk about the rules of engagement for tonight. A little bit of by the numbers on like kind of what happens in the United States. I think one of the big elephants in the room always for a discussion like this is the financial environment, both from the standpoint of the spine surgeon, but also from the standpoint of the implant companies, which at the end of the day are big promoters of, certain techniques and certain approaches to these cases. And then we're going to get into our cases from our four fellows who will introduce themselves as they go along and have all been crushing it this year. All right, so rules of engagement. Oops. Patients must have myelopathy. That's kind of what we're talking about. The Radic thing is an add-on which I think emphasizes some of the relative strengths and downsides of different approaches. We want to have everybody have neutral or lordotic alignment in particular because if you have myelopathy and you have a kyphotic alignment, it sort of pushes everybody to one approach and it's like a little less exciting. And then we don't want anybody to have been treated with D-tracks. And that's like more like a personal thing, like weird. I don't totally understand why you do that. And so that's not an approach that we're going to talk about tonight. And so by the numbers, this is really, and this is like a little bit of a sloppy, like you can't find exactly how many patients with myelopathy get treated with what. This is a little bit of a general, kind of ballpark percentages in terms of like the prevalence of these cases. If you look across a bunch of different recent papers in the United States, but like 40% ACDF, 19% disc replacement, 36% posterior approach with a fusion, and then laminoplasty, like right or wrong, is really bringing up the rear with a small percentage. And so I think like that's something that's interesting to keep in mind. That number is also like these numbers are widely variable if you look across the globe in terms of like how this problem gets treated elsewhere. And what I think that more than anything that tells you that like we probably haven't arrived at the final truth of like what this distribution should be. And I think just tuck these numbers in the back of your mind because they're really interesting, and it probably speaks more to the biases that we see, in the United States in relationship to the next thing I want to touch on briefly, which is the financial environment. So, from a surgeon perspective, ACDF and PCDF reimbursement are kind of like in the same ballpark. Like, it's not factors of, like a factor of 10 different. It's a small multiplier, it's probably 1 point something. The big elephant in the room is the reimbursement for PCDF versus laminoplasty, in my opinion. And this is as coming from someone who really doesn't do laminoplasty for a variety of reasons, and we can talk about that later. But like, it's a big number, 2.5, 2.0, 3.0, depending on like your hospital's reimbursement and your insurance contracts and Medicare versus private payer and stuff like that. So like that's a big factor that, like it or not, probably moves the needle. So we're gonna just leave that be. That's not a feature of this discussion, but it's something I think you got to think about in terms of like why people do what. So from an industry perspective, it still is. It's even a bigger disparity. So laminoplasty plates, and this is without revealing any contracts about the place that I work, are less than $1,500. ACDF 2-level plate and 6 screws, less than $1,500. PCDF instrumentation, that's a lot more. And so again, you got to think of are there institutional biases towards this? Rick?
Chris, was that minus the cage or whatever you're putting in the interspace for the ACDF?
So the ACDF, that's minus the cage, and the reason I left it out is because at least at our institution, it's not always the same vendor that sells the plate and the whatever is in between the vertebral bodies. Our practice bias is a little bit towards allograft, and so like that's often a different vendor than who's putting on the plate. So like that definitely moves the needle though. Towards ACDF if you're at a place where you're putting in a titanium or a PEEK cage, or if the vendor for the plate and the screws is the same as for the allograft. I would say the allograft is, for 2 levels is probably not a dissimilar price to the metal for us. And then PCDF is, go ahead.
And that's got to be a little bit regional because we see, at least in the DFW area, except for Aetna, which prescribes you have to use allograft for 1 or 2 level, almost everybody uses either PEEK or titanium cages, at least in our area.
Sure. So why do you think?
Why?
Yeah.
Because they don't subside or fracture like allografts do?
A titanium cage that's much stiffer doesn't subside.
Well,
Well, he's talking about like a 3D printed cage.
Yeah,
no. I'm just talking
It's
about.
still stiffer.
I think allograft, which was what we all were brought up on at our kind of stage in our career, which was the standard, I think has been supplanted structurally by either PEEK or titanium because they don't either subside or crumble. And that's just in our area. I mean, again, we're kind of forced by Aetna to use them for 1 or 2 level, but left aside, almost everybody, at least in DFW, not just TBI, but in the community, will use a cage.
Sure. I mean, I see that. I mean, there may be like some minor reimbursement issues with that. I don't think there's ever been a titanium cage made that the modulus has been as soft as bone, and you see it. I mean, I think that's one of the things I hate about a titanium cage is like when when a piece of bone or a PEEK cage subsides, like you could probably like put that X-ray up in the office and like no one says anything. When you put the titanium cage that subsided and the end plate up, like everybody notices where that cage is and it's not where it was supposed to be. But like I recognize that is a big pressure, and like I have like a 1960s era practice, so like that's why I still use allograft bone.
Yeah, and I totally get that, and and I mean, you're talking to somebody who probably does like less than 6 ACDFs a year. I mean, it's just not a huge thing, but it does seem to maintain the correction better, PEEK or titanium, at least what I've seen. And
I will hope for the sake of Rothman Institute's reputation at the TBI that like our ACDF case has cages. All right. So, and then the last thing is just moving on to the cases. I think that Alex, you ready to go first?
Yeah, absolutely.
All right, go for it. I'm gonna take away screen sharing. Trying. Not. Okay, I'm off. Sorry.
Just a second. Sharing my screen. All right, can everyone see that?
Perfect. Yeah, it's good.
All right, so my name is Alex Crawford. I'm one of the spine fellows at Rothman, as Dr. Kepler mentioned. And I'll just sort of jump right into it. So this is a 51-year-old male patient DT who comes in with imbalance, some hand dexterity issues, and pain radiating down sort of the back of his right arm into the middle finger ish on the right side. In terms of a past medical history, he's relatively healthy hypertension. Pertinent social history, though, he has been a pack per day smoker for quite some time. His exam, he's fully intact in his uppers and lowers in terms of his motors and sensories. Symmetric 2+ reflexes throughout his uppers and lowers. He does have a positive Hoffman bilaterally, though. He does have difficulty with tandem gait. And here are his pre-op x-rays, so AP and lateral cervical spine x-rays that demonstrate sort of diffuse spondylosis. No evidence of spondylolisthesis here. He has maintenance of cervical lordosis as well. Moving on, FlexX films demonstrate no evidence of dynamic instability here. And then the MRI. So he has, I would say, a component of maybe mild congenital stenosis and some slight disc herniation, some uncovertebral facet hypertrophy that's contributing to sort of flattening of the cord throughout the subaxial cervical spine, all the way from C3 really to C7. He also notably has left-sided severe foraminal stenosis at C5-6, and on the right side at C6-7. But just as a reminder, in terms of his pre-op complaints, he does have pain radiating down the right arm in sort of a C7 distribution, nothing down the left arm though. So the sort of one-liner about this patient's 51-year-old smoker with myeloradiculopathy, including a right C7 pain and tingling, but no motor deficits associated with that radiculopathy, no numbness. And like I said, he is a smoker. So I'll pause here to just sort of open it up for discussion in terms of potential surgical options for this guy.
Okay, so does he need one way or the other? I'm not asking you, Alex. Not that I disrespect your opinion, but I know you know this is what happened. Does this guy definitely need a foraminotomy? Who would, whatever they would do would include a foraminotomy?
I think that's a very good question, and that's kind of part of why I bring up this case.
Right, exactly. So like everybody else, like I would do it. I'll tell you right now, I would try to, whatever I do, I would try to include some sort of foraminotomy because, like, you know, that's a part of his pain, and like if his myelopathy doesn't get better, like, you know, that might be God's will, you know, so to speak. But like if his arm pain doesn't get better, like that's a problem that you told him you're going to fix. But that's just me.
Does he have long track signs? Did I miss that on a slide, or is this guy just
He's got
C7 radiculopathy?
He's got a positive Hoffman bilaterally, and he has difficulty with tandem gait.
But does he have hyperreflexia, hypertonicity, clonus?
No.
You know, Hoffman's is not 100% reliable sign.
So,
and does he have any other balance issues or fine motor movements with his hands?
He had slight issues with fine motor skills, not really as overt as his balance issues. He did struggle with Romberg as well. I didn't write that down.
You know, I think Rick and Jack bring up a really good point, and I was going to mention it during Chris's introduction, is if we're going to define myelopathy by a long track sign or two, that's one thing. But then we have the people that come in our office that are really like having difficulty with balance or buttoning, you know, clothes and things like, I mean, there's myelopathy, a couple long track signs, and clinically functionally limiting myelopathy. And that's, I think, two different animals.
And
like in what
Chris,
sense? Like you go ahead. Sorry, go ahead.
No, I was going to say, Chris, so this patient displays signs of myelopathy and radiculopathy. So would you ignore the myelopathy signs and just say, okay, let's try to see if we can get rid of your C7 pain?
I mean, like sometimes I guess I've been there before. Like I understand the question. I certainly have been there before where like, you know, you're not that bad off. I mean, that's like a little paternalistic, but like I'm willing to go there. Like, yeah, like you're not that bad off. let's like what your problem is your arm pain. And then you see if they bite on that. And then like I've treated that, like where you just get rid of the arm pain. You say like, listen, but come back when your hands get really bad, or when your balance is really bad. I think like maybe the answer for right now is not to like adjudicate that, um, but to say like we're in a myelopathy discussion. And so let's just say for the sake of this discussion, like let's assume that myelopathy is the real deal. And Bloom and Scott, so like Dr. Blumenthal, like, are you saying that like is the clinical myelopathy worse, or is the signs of spinal cord dysfunction worse in your mind? Or are they equal?
And I think in terms of decision making, in this particular case, if they've got a couple long track signs, but their main complaint is a right C7 radic,
Then you blow it off.
and I think Rick just mentioned that. It's like, okay, you want to get the right C7 radiculopathy, the pain, whatever, paresthesias, weakness
Because
gone.
they're going to hate you if you don't make that better.
And who cares if they've got, you see them back in follow-up 6 months later, their fusion or whatever is healed, and they're still got a positive Hoffman's and a little hyperreflexia.
Right.
That's not going to change your paradigm.
And I think that answered the question I was asking, which is like the worst problem is the functional difficulties. And so I think this guy may not have like, is Hoffman's or hyperreflexia, but if he's myelopathic from a clinical standpoint, his balance is trash and his hand function's not great or whatever, then I think you got to take that at face value and treat the cord in addition to the radic. Right.
Agreed.
And so like, I guess again, to cycle back to the question is like, would anybody go in with any sort of strategy? Because there's a lot of choices, and not address the radic, but address the myelopathy.
Well, how about the other way? I don't think anybody would say in this case, like, let's just do a foraminotomy for C7 and
Sure.
ignore the spinal cord compression. I don't think you would do that.
Right. Okay, fine. That's a good question. That's a good answer. All right, Alex, go ahead.
Right. So the big reveal, we did do a laminoplasty, C3 to 7. So we did a full laminectomy of C3. This is the DePuy arch instrumentation with rib allograft actually to hinge open that defect, that trough. And the laminoplasty is from C4 to C6, and then we did a dome laminectomy of C7 as well. We actually did not do a foraminotomy in this case because the attending who I did this with tends to not do foraminotomies in this setting, even when one of the complaints is radiculopathy or radiculopathic in nature.
Aim that criminal. Just kidding. Don't say anything.
So let me ask you a question. So you've done a laminoplasty, you're looking at the cord, you've expanded the canal. What's the downside of taking a few bites with a kerosene into the foramen and doing a foraminotomy? Like, why would you not do that?
I think that's a perfectly reasonable question, and I think it begs the answer that I would provide as well. But I think the concern among some is that by doing a foraminotomy, particularly if you wind up taking a little bit more than you were intending to, you could destabilize something. Or at least that's what some of the literature talks about in terms of whether or not to do a foraminotomy in the setting of the laminoplasty.
I think that's kind of a thing. Like I don't, again, I don't do a ton of laminoplasty, but like I do think that people that do it are apprehensive about combining that procedure with a foraminotomy in a way that you don't really see in the setting of a fusion. What do you think?
I mean, Chris, when I used to do these, we used to routinely, decompress at least the C5 nerve root. And as Scott said, you're looking, if you do the open side and the symptomatic side,
No, right.
you're
It's
looking
easy.
right
It's
at
easy
it.
on that side.
Yeah.
Actually, Alex, do you know out of curiosity? I mean, I guess only because there's not a side marker on this. Was the open the open side the same as the radic side?
No, that's a good question. No, so this attending tends to do the open side on the left, kind of every case for the most part.
On every case, really?
Sucks to be right-handed.
Okay, so Alex, let me ask you a question. You talked about the philosophy of not doing a foraminotomy for destabilizing. So tell me how removing the entire lamina spinous process of C3 is any less destabilizing than doing a foraminotomy.
No, I completely agree with you. I think you have a very solid point there. I also have a study that I'll bring up in a couple of slides that would suggest that doing the foraminotomy does not tend to destabilize the spine. Although,
all right, so Alex, why don't you rip through the rest of the case and then get to, because I know you prepared some slides at the end.
Yep, sounds good. So here are the FlexX films. This is at 3 months post-op. I didn't include the measurements here, but if you compare pre-op FlexX to post-op FlexX, the range of motion is actually fairly similar pre-op to post-op. I think he lost maybe 1 degree of the flexion extension arc, at least on my measurement.
That's less than the 5 degrees that we assume for a cob.
Yeah, exactly. Yeah. Well within the margin of error. So this is the post-op note 3 months out. He hasn't followed up since then just yet. He's scheduled for a 1-year follow-up as well, but not having any neck pain, actually does not have any arm pain either, despite the lack of a
Hate that.
foraminotomy.
By the way, hate that.
Yeah. Slight issues with balance still, though he thinks that that's slightly improved compared to pre-op. Similar with regard to hand function. He is back to work. I think if I recall, he's a card dealer at a casino. And exam essentially very similar to pre-op as you might expect.
Can you remind me, Alex, I'm sorry, how old was he roughly?
51, I think.
50s. Okay. So like, youngish guy for myelopathy. I don't know. Like, so what's the experience of doing a central decompression and arm pain going away? Like, did we get lucky?
That segues right into my next slide. So
Wow.
this is a study from the Spine Journal published in 2018. And this group out of, I believe, South Korea, if I recall, looked at laminoplasty versus laminoplasty and foraminotomy for myeloradiculopathy. Like I said, this is a small study. It's not adequately powered to appropriately adjust for potential confounders. There are only 26 patients in the laminoplasty alone group. There are 40 patients in the laminoplasty and foraminotomy group. But even still, at 2 years, there was a difference in terms of how patients responded in terms of their arm pain. So the arm pain was significantly improved in both cohorts. So that sort of, I think, gets at your question, Dr. Kepler. We should expect arm pain to improve a little bit, at least based on this study, even with just the laminoplasty alone. But in the foraminotomy cohort, the arm pain improved to a greater degree. So you can see that the VAS arm pain was pretty similar in both cohorts at baseline, 5.5 basically. And in the foraminotomy group, it dropped to 1.8 post-op at 2 years. And in the laminoplasty alone group, it dropped to 3.4. And in reference to the earlier question about potential instability, there was no difference in post-op kyphosis or instability between cohorts. But again, small study. I don't know if it's truly adequately powered to detect a difference.
Yeah, I don't know. So let's, before we because we're 25 minutes in, what do we get? We have an hour, right?
Yeah.
Okay, so
Yeah,
before we go too long in this, so what do you guys think? Like, so what's the 5.4 to 3.4? Like, why do some people get better from a central decompression? Is this like some the mythical lateral recess stenosis in the cervical spine? Or is this like dumb luck?
How do you know that surgically they didn't take a few foraminotomy bites into the foramen and without doing like a big old foraminotomy? I mean,
because they said they didn't. Because they said they didn't.
And they didn't.
That's
Yeah, but if their open
that's-
trough was a millimeter lateral versus a millimeter medial, you catch the entrance to the root into the foramen. So it's hard to know. And with this number again, you don't even know whether that's statistically significant. Yeah.
Fine. All right. So okay, so I'll ask it a different way. Do you think that you can improve arm pain without a foraminal decompression in the cervical spine?
I mean, yeah, I think you can, but even this is small, Lou. Look at it. So it went from 5.5 to 1.8 in the that was the laminoplasty with the foraminotomy, yes or no?
Correct. Yep.
Yeah.
Okay. And with that, it went to 3.4. Well, patients come in, they complain of 3.2
Yeah. No.
pain.
Like you wouldn't feel good if someone has 3.4 pain in the arm.
Yeah, I
Right.
mean, I wouldn't consider that to be so successful. I mean,
It's not a
you do
win.
lumbar lami, and if they still have a 3 to 4 out of 10 pain, that's not great.
Yes.
I
Yeah,
think
fine.
that's why a lot of people tend to do the open side on the symptomatic side in patients with unilateral radiculopathy.
I mean, so like
But
that's
there is
great.
some
That's a great
literature that
takeaway.
shows that even the hinge side where you don't do the foraminotomy can improve if you have bilateral radiculopathy. So, I think the jury's still out on whether you need to do it or not. But as Scott said, when you're opening the hinge, it just another undercutting bite or two, makes the foraminotomy done.
So if I
And
ever
also,
start
as you
doing
said, Jack, if you're cut just a little further laterally, you essentially are opening up the lateral recess and opening up the entrance of the
lateral
foramen.
recess, it's not a thing. All right. So listen, if I ever start doing laminoplasty, I'll do the open hinge on the open part on the side where the arm pain is.
Yes.
All
It's a
right,
great,
thanks.
Great.
it's a great operation, especially in a teaching setting. This is a
Yeah.
much easier operation to teach and see the pathology than trying to do a multiple level corpectomy through, a
Yeah.
2-inch
Well,
incision.
yeah, only one person can see.
Right.
Agreed. All right. Anything else, Alex, or can we switch?
No, that's good. Good place to stop.
All
So
right.
let me stop.
Nice job,
move
Alex.
on.
Thank you.
Let's go to Zach, are you on, or should we do Hunter first?
Yeah, I'm on. I'm ready.
All right, go for it.
Okay, perfect.
These guys all got the new format that Rothman forces them to use. Mine's like this old one. I'm probably gonna get an email later tonight from Vaquero. It's like that's
Oh,
not the
I
proper
already
format.
told Alex you're using the old one. Don't worry.
He has moles everywhere. I knew it.
All right, so a second case here for us. So this is a 32-year-old female. She came into clinic with a chief complaint of balance and dexterity issues, also with left upper extremity radiating pain. Her pain had started 8 weeks prior, acutely when she woke up one morning. She didn't have any known trauma or event that preceded the pain. Her symptoms have been progressively worsening. The pain predominantly radiates into the left thumb and index finger, and with associated numbness and tingling, but no bowel or bladder dysfunction. She's otherwise healthy and works in HR for a local company. She hasn't had any previous surgeries. Here's some pertinent findings from her exam. She has an unsteady tandem gait, but she is able to heel toe walk. She has 4 out of 5 left wrist extension and diminished sensation to light touch in the left C6 distribution. She has positive Hoffman's, more on the left than the right, 3+ left patella reflex, and then 4 to 5 beats of ankle clonus bilaterally. Her pre-op x-rays are here. You can see that overall a relatively healthy appearing spine, though she does have some spondylotic type changes with osteophyte at the anterior body of C5, C6. On flexion extension, there's no dynamic instability or anything of that nature. And then here's her MRI that she presents with, and you can see a large disc herniation at C5, 6. Which is slightly off to the left side, but more or less in the midline, but does lead to some kind of foraminal narrowing, but predominantly cord compression at this level. So we'll pause here to discuss surgical options and what people would do in this situation.
And you said it was left arm pain?
There is left arm pain in a C6 distribution that matches the level of this MRI.
Well, I know. I
think-
mean, I know what I would do.
Yeah, we know what we would do.
Yeah.
I think Chris
and
is,
detracts,
baiting us here.
Anterior detracts.
We're this is like baiting the heck out of this. This is the not even the most baiting example of the night, but like go ahead.
Yeah, well, patient needs an anterior decompression, and then it's just a question of what do you do for reconstruction. And I think we'd make the argument as a young person with a healthy looking spine, and obviously, either one is going to do fine.
5'6" is healthy.
No, 5'6" is not. 5'6" needs to come out, but the rest of her spine looks pretty
Okay,
healthy.
fine.
Yeah, so we know that an ACDF will do fine for her, but we think that there's an advantage when you can do either one in reconstructing with a disc replacement, as far as saving the rest of the cervical spine for her later years.
Yeah, so the big question is whether you believe the literature about adjacent segment disease. And
Right.
obviously, we
Don't even say
and-
that.
Listen,
and
Alan
I'll-
Hillebrand is the
Hey,
one
Alan
that wrote
Hilbert,
it.
you might be listening. Don't
Yeah,
say
Alan,
that,
yeah.
Dr. Pinto.
Face
Of
nothing.
course
I'll
it's
use-
true.
I'll-
80%.
I'll use Jack Ziegler's analogies. We've drank the Kool-Aid and believe that the incidence of adjacent segment with disc replacement next to fusion is a third to fourth less.
Yeah, I mean, like, long live Dr. Bowman. So we can all bow our heads, like that was the genesis for that whole project.
Mhm.
And you guys are carrying the torch for him.
Two
So
questions.
in other words, we would do a disc replacement hands down, Chris, in somebody
Yeah.
like that.
Two questions that I'll ask specific to this patient, and I'll go back to x-rays. So number one, she obviously has this large osteophyte on the front of C5 and C6, so she's something of a bone former. Does that give you any pause for doing a disc replacement, or does it change anything that you do intraoperatively to prevent HO formation or the likelihood of spontaneous autofusion?
First of all, we don't remove the spurs, and no, it doesn't deter us from doing it. And
But if you do have to bite off the spur to get better access, a little bone wax goes a long way. I mean, she's not.
So you just shut down the cancellous,
Yeah.
communication, basically.
Yeah, because you can get to that. It's a posterior osteophytes. Obviously, you can't put bone wax on or do anything to it.
Right.
But the ones that you're looking right at, you can
But-
put bone wax on that.
But these are relatively small. We have patients with really, really big ones. And then you'll notice with time, the anterior spurs actually will melt away as you follow the patient 6 months, a year, 2 years out.
Really, even in the setting of preserved motion.
Yes. Yeah.
Why does that happen?
I don't know, Chris. I don't know if it's just sort of a stress reaction to the body, to a collapsed degenerative disc.
Yeah, it's like it's a DDD. It's a DDD thing. It makes sense.
Yeah, but unlike a plate, you don't have to prepare a flatbed for it. So if
Sure.
it's not in your way, you can leave it alone.
Doesn't matter.
Yeah.
So the other thing I'll bring up is the sophisticated patient, like one that might go to TBI or Rothman Institute, that says,
By the way, we don't get them. We don't get them. Just kidding. It's not a rough.
you've got to
But they
get
go to you,
sophisticated
Chris. We know
patients.
there's
It's like,
I'm just kidding.
I'm going to Dr. Kepler and I want you to give me the best 2025 operation. And I've heard artificial disc might be,
Yeah, and I say,
equivalent or
listen,
maybe
there's
a little
there
bit
is
better.
4 directs a day to Dallas.
And that's fine. We have no issue with that. But
I know, just kidding. Go ahead.
But I think you're going to have you have sophisticated patients, obviously, that come to Rothman and say, I know this. People are I've had 3 other doctors that said ACDF, but what about this artificial disc thing, Dr. Kepler or Dr. Pinter? Like, what do you think?
And Zach, the other thing that you should look at when you consider this, if you look at her plain X-rays, the toric ratio is relatively narrow, although her cord was only compressed, I'm assuming,
Yeah.
sagittal.
Yeah,
it didn't look
facet joints and
compressive.
spinal are like the same.
Yeah.
Mhm.
So if you
Yeah.
do a fusion,
It's true.
this gal is a setup definitely for adjacent segment disease.
Yeah, okay, fine. So like she's a setup for adjacent segment disease, probably no matter what you do. Like, let's not paint yourself into a corner there. But
No, but
I agree.
less with
Like,
an
if you have
artificial
any, if you believe in that at all, and with the shadow of Alan Hildebrand hanging over me, like I believe in it. It's totally intuitive. I think that the CDA literature is financially conflicted, but also convincing. And I think that's a real operation. So I think you guys are spitting the truth here. Zach, go ahead.
Yeah.
hey, Chris, I love you, but I really get tired of hearing people say, well, it's conflicted because they paid for the study.
Yeah.
You think who's to pay for the study? These patients were
Nobody.
independently
Yeah, nobody's going to pay
evaluated.
for it
They
otherwise.
fill out
Only-
all their outcome
only-
studies
Yeah,
themselves.
fine.
All right.
Okay, fine. That
Okay.
is true. It's true. And what I said is true. And if you got to do sport, which no one will ever do in the history of medical science again.
They learned their lesson. Yeah.
Yeah, exactly. So fine. But I agree with you. You're right, Geyer. Go ahead.
All right. So in this patient, we did a surgery.
And look at you guys. You're the winners. All right.
The one other question I was going to bring up was, do you have any markers on preoperative films that tell you definitively or close to definitively that you will definitely be able to visualize the level intraoperatively, because this was ended up being a pretty stout young woman, and you can see that the line of her shoulders crosses the disc space here, but we can see it okay. It's just not amazing visualization.
All right, Zach.
You just did a
I want
study
to tell
this
you
year.
something.
Okay, go ahead. Go ahead.
At TBI, we have crackerjack X-ray techs. I don't think that Jack, Scott, or myself have ever bailed out on a case because we couldn't see, even in the rare case of a C17-1 or a real muscle, weightlifter that we need to see C6-7. It just doesn't happen. I mean, we're always able to see, and we have the latest X-ray or C arms that are low energy that you really have to squint to see everything. But our X-ray techs work magic.
Okay.
And so, and no weighting on the arms, no pulling down the arms, no nothing.
No, we do. Well, Jack will use intraoperative traction. I just pull the arms down. Scott, I don't know if you use
you wear lead and you just pull the arms down a bit?
No, I tape the arms down, Chris.
No, we tape them down. Tape them down.
Yeah, I tape the
You
arms
mean like
down.
on the shoulders?
Uh-huh.
Yeah, I
Yes.
tape the arms down from the
Top of
shoulders.
shoulders.
Yeah, fine. We do that too. No one
And then
pulls them though.
And we tape them to the table.
Well,
Yeah.
we tape them to a footboard. So that's the secret. Because if you tape them to the table, they can slide down. But if you get a 90-degree footboard and tape it to the footboard, their extended lower extremities doesn't allow them to slide down. So you can get more pull.
Jack, I stopped using a footboard, but I pull them down to the bottom of the table.
Because you
doesn't
broke
make any
the one I gave you.
Well, yeah. So, and technically, you can see on the AP the bilateral foraminotomies, which you need to do technically with an ADR, are beautiful. I mean, those are symmetric, wonderful foraminotomies, which in a motion preserving surgery, you can't rely on any remodeling.
No indirect. There's no
That's
indirect. Yeah.
That's really well done. And Zach and I were talking about the Russ study that showed the highest incidence of failure was either inadequate or recurrent foraminal stenosis. This one will not have it because that's just a beautiful foraminotomy.
And it was beautifully done, Zach. Perfect, centered on AP and lateral.
Zach, you're the best ever. All right, let's go.
I'm going to do these every time now. No more ACDF.
Yeah,
That's
exactly.
right.
We'll do something the shit out of you. Just kidding.
Yeah. So this is the 2-month
That's
postoperative
great.
film. Patient is doing really well. The left arm pain completely resolved. Her numbness, tingling, dexterity, and balance issues have all greatly improved, and she went back to work 2 weeks after surgery.
All right. So Rothman. Okay, sorry. Go ahead.
No. Only if we have time. I was going to bring up
5
something.
minutes. 5 minutes. 5 minutes.
All right. So obviously we use the ProDisc C Vivo with the which is really keelless. It has these very small little triangular fixation points. There's these other ProDisc models that are out there that have keels. For those of you who do a lot of cervical disc arthroplasty and have been involved with implant design, I don't know if you could speak to the pros, cons, what your thoughts are with regards to different designs such as these.
Well, you asked the right crew.
Yeah.
Well, the Vivo is great for the patient that doesn't have much remodeling of the end plates. There's still concavity on the superior end plate, and it's really like doing a Mobi C, except it's has a better articulation. It's the same articulation as the original, or what they call the OG, the ProDisc C, that's all the way to the right. Except that we used to cut the keels, then we started milling it with the drill. And some people feel it's a little more stable than the SK with the short keels. I don't know if that's true. I've never seen any data. So I either use Vivo or SK, and
What's nice is you can mix and match this to the patient's anatomy. So it's nice to have the option. The articulation is exactly the same. So it's really just the bone metal interface.
Yeah.
All right, let's move on from there just because we're getting a little bit short on time, and then let's go to Hunter.
Sounds good.
But that was a nice case. That was right in the IDE sweet spot, right down the middle of the plate. So there are plenty of those patients now with very long-term follow-up who continue to do extremely well. So
and again, like despite what I said earlier, it actually is a wonderful body of literature. I was trying to like create a little controversy, but I tell patients all the time, like, this is an equivalent operation. Maybe it's a little less than you guys say, but like I think it's a great body of literature to say patients with the TDR do amazing.
Yeah, I think it's the best literature we've really ever produced. I mean, in any orthopedic implant.
Well, I mean, the hip
Well,
replacement surgeons would argue.
they never had to do a prospective randomized multi-center trial, you know?
Yeah, because yeah, fine. Okay, fair. That's true. All right, take it away,
All
Hunter.
right. All right. Can everybody see it okay?
Yeah,
Yeah,
Hunter, get it. You're in the
kind of got these
presentation
weird
mode.
note things. Take that away and put the screenshot, like the presentation. There you go. That's not still not it. It's the one that. Nope, that's still not it.
There.
That's it.
Perfect.
Okay. Perfect. All right. So my name's Hunter Waddell. I'm one of the spine fellows here at Rothman. Thank you guys for having us tonight just to talk through some cases on an interesting topic. This patient of ours is a 43-year-old gentleman who's had 2 years of progressive right arm pain, weakness, issues with balance as well as altered gait, and fine motor skill problems. Sorry. No notable past medical history. On his exam, he's got right trap pain going into his shoulder and the radial aspect of his arm. Does not go past his elbow. He's got bilateral hand numbness. He does have extreme difficulty with tandem gait, and he's got some long track signs. Notable weakness in his right upper extremity, mostly in his deltoid and his bicep, with some trace weakness with his wrist extensors, tricep, and otherwise he's neuro intact in his left and bilateral lower extremities. Of note, he has kind of had symptoms of kind of mild myelopathy for the last 2 years, but in the last 2 months or so, he has felt a notable decline as far as his balance and fine motor problems really causing a functional disturbance for him. Here is the preoperative radiographs showing the neutral lateral as well as the AP radiograph showing that he's got an overall kind of neutral alignment, no kind of focal kyphosis, multi-level degenerative changes throughout the cervical spine. Here's his flexion extension radiographs in the clinic showing that, you know, he does have maybe a grade 1 spondy at 2-3 there, but does not have any dynamic instability with motion. Here is his preoperative MRI that he came to clinic with, the T2 sagittal image showing multi-level stenosis, and then the correlating axial images from C3 down to C6-7. And at C3-4 as well as 6-7, he's got largely kind of foraminal stenosis, worse on the right side, which is his symptomatic side. And then in the middle levels, he does have, you know, severe flattening of the cord and central stenosis. Just wanted to pause at this point to kind of get everyone's thoughts on their surgical management and kind of which points of this patient's case would push you in one direction versus the other.
So
Hunter, how old is he?
Neutral.
He's 43.
He's young, a young guy. So I mean, I think this. So first of all, this is my patient. Not to maybe it's biases everybody, but he gets at least to neutral. He's really young, but he is very weak in the right arm. You know, which you know, I don't know. I'm not sure if that changes. Like we've already talked about, like how with foraminotomy or with laminoplasty, you can do foraminotomy. Obviously, ACDF gets you there. PCDF with foraminotomy gets you there. He's probably not a great disc replacement candidate. I mean, maybe in some parts of the world, but what would you guys think? Maybe back up to the I think Hunter that's probably the best view because it shows you like the sagittal cuts are like basically true to life in terms of like the sagittal alignment.
And what did his neutral? Can you go back to his neutral on lateral?
He's neutral, he's straight. His extension, he's like maybe, I don't know, he's probably still straight.
Yeah, okay. So he didn't do much. Okay.
He didn't do much.
Do you think that you can get
He only has
as
14.
good a sagittal correction posteriorly as anteriorly?
But like,
decompression,
does that matter?
obviously.
Well, does that matter?
Yeah, maybe not. I mean, obviously you got to get his cord decompressed.
Right.
But you probably like for the long term, since he's so young, like to get a decent sagittal correction as well, I'm thinking. But you're right, Chris. I mean, in Europe, if he goes to the right doctor, they might offer him a 4-level disc replacement. He might get a 4-level anterior with posterior screws or all posterior if you feel like you can get a good enough, correction posteriorly, because you can get the decompression posteriorly, if you can get a decent restoration of lordosis, then all posterior is not a bad option here.
I mean, so that's like the rub. This is like such an archetype of this whole like, case series, which is like you can do anything, you gotta do anything.
Yeah.
I think that's like the sort of like that what you just said is the exact situation on what we're talking about, which is like there's probably not a right answer.
Well, I think, Chris, a lot of it comes down to your own bias, but I always try to use what would I want done if that was me or as my brother,
I mean, yeah, so like what I would want is the ACDF. Probably, or something from the front. Like it's so much easier for the patient. Like patients who I wouldn't have the guts, given his neutral alignment, probably, and the big component of radicular symptoms. I probably wouldn't have the guts to do a laminoplasty here. I'm minded on a PCDF.
Chris, but how many ACDFs? 1, 2, 3, 4. How
It's
many?
a lot. It's a
Yeah,
lot.
and then once you hit 3, aren't you
Then
committed to a
50%,
posterior?
like, what do you tell people? So that's what the discussion here is probably.
So,
Like,
Chris, why wouldn't you consider the laminoplasty? Granted, he's straight up top, but if you look at the C6-7 level, he starts the cord falls posteriorly, and if you do the laminoplasty, at least decompress his cord, then you can go back later and do your ACDFs, and you can get your lordosis back, but you haven't fused them. If you feel so inclined to get his alignment so that he's better off in the future. I'm not saying it's right. I'm just throwing it out.
I guess my take on it is like in the first breath you say like if it doesn't work then you're doing something else. Like I don't know. It just sounds like you're kind of like doing something because maybe it's less invasive, but you may not win at all the levels, and then you're going to go back and do something else later. Which sometimes with eyes wide open for a patient, that's not a bad thought. Like you tell them what the risks of it are, and the surgery you're going to need later may be less invasive.
And he's in his early 40s, so it's not like he's 60 or
He's
70.
Young. He's young. I mean, his neck doesn't know that.
No, his neck is old as hell.
His neck doesn't really know that, and that's like maybe a part of like where my mind would be at is like, what does his neck think about his age, and like the bottom level. Look at his 6'7". I mean, that disc is shot, and he's got a big loose piece of disc on the symptomatic side that he's really weak in the arm on. So I don't know.
I mean, you're certainly less likely to get the respiratory issues 4 levels from the front in this age than you would if they were in the 70s. So I mean,
Sure.
I think you could do 4-level anterior and get a really good correction, decompression, and everything.
And I love that thought, and that's kind of where my mind's at. But so I think the next question is like, if you do a 4-level ACDF, what do you think about letting that stand, letting the patient in on it, backing it up? Like, what are all like that's I think like the big discussion here in my mind. Again, and like I'll give you a foreshadow. We went from the front, but where do you live with that? And we have a really big divergence of opinion within our practice as far as how you let 4-level ACDF run after the surgery.
I think most of the people in our group would back it up posteriorly.
Yeah, they definitely do anterior posterior.
Yeah.
2 rarely, 4 always, and 3 iffy.
Right. So I'm with you on that. So and my take on it, and I actually do not disagree with him at all, other than sort of like I think this is like where you put your money if you have a bunch of money to invest. Like, are you buying T-bonds? Are you like putting it into like the stock market? It's a Rorschach test. Are you backing this up because that's the least likely chance of you going back into this guy's neck? Or are you telling the patient, you're gonna get a non-union, and when we go in the back, it's gonna be fewer levels, but it's disruptive to your life to go have 2 surgeries. And that's the difference between in a nutshell between Alan and me. And I think Hunter, why don't you go ahead?
Did you do D-tracks, Chris?
I did at every level, and I put screws in, Why not? Just kidding.
Oh,
Yeah,
you're a
so
good
our
man, Chris. You did go front and back. I love it.
yeah. So we did
Can I get a job, Rick?
Absolutely. You'll fit right in at TBI.
Do you like
Thanks.
barbecue?
Yeah, I do. I love it. No, and so that's what he did. Like I went in the front, and I actually, at this point, like Alan has like insidiously got into my brain where I'm like, that's not the wrong answer to like let the patient make the decision based on their personality. Are they more afraid of another surgery, or are they more afraid of a bigger surgery? And like, there's not probably a wrong answer. And so I used to just always do front back. This guy chose, and this has surprised me a couple times. This guy chose to do the front back rather than the front alone, and come back for maybe a smaller P, or maybe he gets lucky and he gets no P. So, I don't know. I
Hey,
don't have an
Chris.
answer to that.
Chris, this is not a criticism, but was it hard to open up this space because he looks pretty straight like the way he was pre-op? I mean, could you not get
No
any
better.
lordosis?
He's no better. I mean, yeah, I mean, we couldn't like. I think we didn't get anything in the front as far as alignment. That's what you mean, right?
Yeah.
No, we didn't. We didn't get anything. Like he had a couple of levels. Like you can see like 3, 4, 4, 5, 5, 6. You can't see 6, 7. But those levels have the cortication on the end plates. Like we didn't take a ton of bone away, and I still didn't get much. Like it just did. I don't know. It's just like sometimes you put the cob in, you turn it back and forth,
Right.
or whatever you do, and like it didn't lordose. And if you look at his prep, 100 flip back. With that end plate cortical surface, like we're distracted compared to what he was pre-op, and I don't think I took a ton of like cortical bone at the end plate, and I go for it again, and we still are not. The alignment's not really better. I don't know.
So I'll say something negative.
Maybe
something positive.
hyperlordotic cages.
So yeah, so the negative would be if you actually use something non-allograft, maybe you could get better lordosis.
Yeah,
But
I mean, so I don't think
the positive is I have never done a 4-level from the front and got a plate that straight. That is amazing that you got that plate down the middle.
That was dumb luck. I photoshopped the heck out of this X-ray. Just kidding.
Okay.
I did. But the funny thing is, like, it's a good point to the first point, which is like, so why doesn't if we believe in allograft bone and it's cut from a dead person's fibula, why doesn't it come hyperlordotic?
Yeah, I don't know.
Doesn't make any sense. Doesn't make any sense. Like you can make a dead piece of bone any shape you want. But maybe it's just like they assume they're selling to people that have 1960s practices and they don't need to change it. Anyway, all right, Hunter, thank you so much. Appreciate it. The TB guys love it. I'm so happy with myself. And let's go to the last one. If you thought the 2 cases ago was triggering you, wait for this one. All right, Raj, you on? Here he is.
Yep, there we go. Can you guys see the screen?
Yep, it's on.
Yeah, put it in. There you go.
Perfect. Okay, great. All right. Well, thanks everybody. Happy to round things out here. So my case is a little bit of a different take, but I think incorporates some principles that we talked about this evening. And it's specifically more of a radiculopathy case. So it's a 72-year-old male who presented to clinic with 8-month history of left-sided neck pain and paresthesias going into the left trapezius and deltoid. He had an interesting surgical history. This was about 17 years before he came into the clinic. He had an ACDF at C5-6 that was subsequently removed, and then he had a cervical disc replacement performed at C6-7, and then 2 years after that had a cervical disc replacement performed at C4-5.
Like you do.
When he presented to clinic, he ultimately had full strength, sensation was intact, no evidence of any type of long tract signs, no myelopathic symptoms. These are his x-rays. So we have AP lateral demonstrating the cervical disc replacement. The hardware from the ACDF plate is obviously removed, but looks like a solid fusion across the 5-6 level. And then we have our flexion extension films, don't demonstrate any significant inflammation. And the MRI, I do apologize for a decent amount of artifact in interpretation, but overall, it looked like there was, at least at the 3-4 level, kind of on the axial. I'll circle back to a separate select image highlighting more foraminal stenosis at the C3-4 level, and then possibly some 4-5 stenosis foraminally as well.
Do you guys get CT scans very much?
Yeah, I mean, yeah, there we go.
So this gentleman did get a CT scan. Let me see if I can play it. So overall, at least the hardware here looked, there weren't any significant issues with it. And then again, that fusion across the 5-6. And specifically kind of at the 3-4 level and the 4-5 level. So I'll pause here, kind of discuss and summarize that we have this patient with more of a left-sided radiculopathy symptoms and a 72-year-old male with this significant surgical history.
So we know we can't redo a C4-5 TDR, but like, what would you do at 3-4?
Yeah, so which nerve root do you think he's getting the symptoms from, Raj?
Oh, sorry.
Yeah, no, it's okay. It's probably more the C5, possibly C4.
And do you believe in EMGs or do a selective nerve root block and see what you get? See if you can really discriminate down to the root?
Yeah, that's a good question. This patient did not have the EMG, but I feel like that's always really challenging to interpret, especially with the nature of who's performing it.
Like he had some trap pains. Is my patient again? So like he had a component of trap pain. So like,
yeah, it's hard to know. But we do selective nerve root blocks for this. Primarily diagnostically. Every once in a while, you hit a home run, you get some therapeutic effect, and the patient goes away. But primarily for the diagnostic part, if you can dissect out what the root is, then you can offer them, a less invasive foraminotomy if he needs it.
So yeah, he had a C4. It is Raj would never know this because it's done outside. He had a C4 transforaminal. It was an epidural. What it was like a meaning steroid? Like you mean like a
Just use the anesthetic alone around the root.
Yeah, so he had a local plus epidural.
And did he get
at the
dramatic relief?
level of the upper disc replacement?
No, it was a 4 transforaminal. So 3-4.
So above.
Okay, so it's a
Above.
C4 nerve root.
Yeah.
Right. But like the symptoms were like trap and deltoid. Like it's one of the things like it's not, like if you believe like the dermatome man, then it's a C4 problem.
Did he get dramatic relief during the anesthetic phase, Chris? I mean, could you make a diagnosis?
I mean, it was more than the anesthetic phase. It was like 2 months of improvement.
So you've isolated it down to his C3-4 level, his C4 root.
I mean, like if you believe in the specificity of like an injection, like I don't know, like
I mean, if it's
you look at like the
specifically
5-minute,
sure.
if you look at the 5-minute fluoro shots of a test injection for a cervical foramen, it's like not so clear, right? It's like 2 levels up, 1 level down.
You're right, Chris. But what you have to do is really talk to the patient and get him. And we have him fill out a little chart because sometimes they say, "Oh, it didn't help." We say, "Didn't help at all." Did you get relief?
No, it helped
5 minutes, 10
sure.
minutes.
Yeah.
But it depends who's doing it. Also, I mean, there's technical parts of it. So if you can have somebody in your gun belt who does really good blocks, I think that's a valuable person to have, as in your practice.
Yeah, but what would be interesting, and this is not out there, and this is only because I've just seen it from looking at having the guys save shots. It would be interesting for us to both have our PM&R docs who do cervical transforaminals to make the patients lay on the table for an extra few minutes and take an X-ray with the dye after the dye injection and see like where it goes, because like I'll tell you right now, like that information is not out there, and like who knows what it is, but that's like a really important thing to like rely. And if the answer is that it's that like that dye stays at the 4 root, that's really great one way. If the answer it doesn't, then it's important in another way. Like I don't think that anybody knows exactly what those do. Like the diagnostic utility of those injections is just empiric,
But I'll tell you practically, Chris, we
Yeah.
rely on people who do a really good job, and they've seldom led us astray. It's not like we've had to bring half the patients back to do the next
No,
level.
no, yeah, I'm not doubting that. That would be, if you guys are great, that's great, but like the world maybe would need to know that. Go ahead. Sorry, Dr. Geyer.
No, no, no. I was just going to say that you have to have good people that do it that you can rely on. That's all.
Sure. All right. So C3-4, disc replacement, fusion, disc replacement. He's been in five ID
Foraminotomy.
trial. He's been in 5 ID trials.
Foraminotomy. If I thought it was really that C4 root, I'd send him to one of my partners who can do this minimally invasively, either through a tube or endoscopically.
All right, fine. Go, Raj.
Perfect. I'm glad I left that part out prior to this, because that's exactly what he ended up having done is a prep workup. So the nerve root injection, and he did end up having near complete resolution of his symptoms, although it was relatively temporary. And ultimately, C3-4 and 4-5 left-sided foraminitis was the decision. So post-op course, hospital course, patient's left arm symptoms were improved. He was discharged post-op day 1. At the 2-week visit, he reported resolution of the left-sided symptoms, maintained full strength sensation. At 6 weeks, he was kind of progressed to really no restriction in his activities. And at 4 months, he was made a follow-up as needed with neck and arm pain resolved.
It's a great solution. Really is.
Perfect.
Minimally disruptive solution.
Right. And so again, it's my patient, but like really what I think is like I should probably be doing a ton more foraminotomies than I do. And like this is like a little bit get back to like, not on the slide exactly, but like the spine surgical world right now doesn't do a ton of cervical foraminotomies. And like if you look at the literature, which is like it's an antiquated literature, but it's like it's so positive. We probably underutilize that as a treatment, as a surgical treatment by a ton.
Agreed.
Chris, I think you said in the very beginning, you said the elephant in the room was the disparity between
Right.
what we paid for a procedure. If we were getting paid for cervical radiculopathy, and you can do whatever you want, you can do, anterior, posterior, you can do a laminoplasty, you can do a disc replacement, you would see, I think, a big difference in the treatment.
I'm like, go ahead.
I was going to say, Randy Davis has his hand up. He's been waiting patiently. Randy, got something good?
You're too patient for this forum.
I have many. Okay, I have many good things to see. I don't know if you can see me, but I think Chris has done a phenomenal job. One of my jobs with Charlie Mick, who was the prior president of NAS, is to do authorizations, and I have been sent a number of cases from Chris that I have never denied, but I have had to deny.
Hey, sir.
I've had to deny Alex Vaccaro. And then I had to do one with Dan Rue, which is like talking to the Elvis of spine surgery. But my feeling about the anterior procedures is I presented a paper at CSRS a number of years ago that we described 80 to 90% fusion with 3 to 4 levels anteriorly. So I am constantly concerned when I see all of these cases that constantly come back now, automatically anterior, posterior. Why not wait, see how the patient does anteriorly, and then see if you need to do something posteriorly? So that's my question for you guys.
I mean, I actually, again, coming from a position where that was not my initial perspective on the situation, hearing Alan talk that through, like I am a believer a little bit, as long as you have a patient that you can speak to and inform them about the like eyes wide open risks of that, because who's to say that a smaller procedure later with a certain percentage of likelihood of needing it is worse than doing it's a big whack. I mean, like a PCF, patients hate that. Patients hate that. So I'm totally on board. I
They
appreciate
hate that. And Alan at CSRS many years ago, when I presented that paper, he said, "No, I don't believe you." I go, "Well, okay, but patients hate posterior cervical fusions. They hurt more, they have more muscle damage, and a bunch of things." And Alan and I have had several discussions about that since then, and he's been a bit more not too accommodating, but for Alan a little bit.
Can't give in. You can't give in.
Yeah.
Yeah, but that's his take on it now. Is like he lets the patient decide. He actually advocates A only. So,
Well, I'm glad.
Really?
Maybe my little contribution helped him to convince him of that. So,
Hey, Chris, we're over time, but it's been an enjoyable overtime. It's a great topic, great cases, and spectacular discussion. So
no, a ton of fun.
Yeah.
Appreciate it. Appreciate the opportunity. We always love it. We'll be back for all the lickings we can get. Keep on fighting, everybody.
Hey, Chris, thanks again.
Thank you.
And I just want to say my brother loves you too.
I know it turned out great. Thanks so much.
Yes, thank you.
Take care.
All right.
So
and
come-
thanks all
come
the-
on out. We'll
Thank
get you
you
some.
all.
We'll get you some barbecue if you come out.
thank you all. Have a good night.
Thank
All
you,
right,
guys.
bye.
Take care.
Bye.
Thank you.
Bye.
Good night.
And look for an email from Corey about CME. Bye-bye.
Good night.